Again, through the webinar, there'll be points where we'll have questions that we'll be asking participants, and we're really excited to hear responses and engage in conversation about the work we do, specifically around issues addressing finding positives. So in order to talk, you press *7 to mute your line, *6, and again, mute lines individually. And if you don't want to speak up, for those of us who are a little shy, certainly go ahead and use the chat option, okay, and enter any questions or comments related to the conversation.
Good morning, this is Bolivar Nieto, and in continuing with the housekeeping, it says about not to forget to filling out an evaluation at the end. There is a short evaluation that is created by the service. However, during next meeting, we will have the overall evaluation of this webinar series that will be connected directly to the post email, and it will take you to a SurveyMonkey evaluation about this specific webinar. So we are here to Finding Positives Part 2. Last week we introduced the topic. Some of the information presented to start a foundation was around the changes in the field with the National HIV/AIDS strategy, the high impact prevention, and how this is transforming the implementation or the work in the field in terms of HIV prevention with positives, with negatives, combination of prevention, biomedical, etc. This is the time for a review on the additional information that we provided last week. After the introduction of the different changes, we also talk about a formula that it was the interaction between the person and the environment that leads to a specific behavior, and the behavior leads to a health outcome.
So going along with that, in terms of we saw our little favorite formula, behavior equals a person times the environment. We sort of use this formula to refine, to get an idea of like who the population is, like really break down. We really focused in on the personal characteristics, or the P in the formula, and sort of refining the population, right? And again, in terms of refining the population, we talked about what is that, and what are we talking about here? And it's about really taking into consideration experiences. We talked about social networks. We had a couple of poll questions addressing risk, and how certain populations are at greater risk due to our social networks, and how our social networks can work for us or quote-unquote work against us, so to speak, right? And also we talked about norms. As part of the social networks, as part of those determinants or factors of experiences and environments, we talked about norms, we talked about values, and how people navigate certain spaces, how people navigate their cultures, language, relationships. I mean, we talked about, we sort of, so to speak, itemized several factors, but again, certainly not covering it all. It was not an exhaustive list, but just looking and starting to think about the complexity of environments, the complexity of experiences, and sort of how do we navigate those experiences, how do we use data, how do we use information to make sense of the experiences to inform our work, again with the objective of finding positives.
It was part of our homework to do this initial segmentation based on what we call population characteristics. And under those population characteristics, we review the predisposing characteristics, demographics, age, gender, for example, a social structure, education, occupation, ethnicity, and other factors measuring status in the community, coping mechanisms, health of environment. We also talk about the enabling resources. And here in terms of describing this, we go more sort of like employment, stable housing, social support, and last but not least, the perception of needs, health beliefs, attitudes, knowledge, values, and what are these notions within the individual. So these create what is the population characteristic. Part of the homework was to do this initial segmentation of the population or person or target population as we call it, to later during this webinar move to the environment. And what we came up as an example last week, you have it here. We have two distinct scenarios that talks about a person. As you see here, there's no plural. It's about a specific person. We talk about like who is most at risk in these two scenarios. And also the question posed was what's missing. And that's what we're going to talk about today. Not only talk about the population characteristics, but we're going to now include the environment and how these two are equal to a specific health behavior. It could be unprotected sex, it could be not testing, it could be not sharing syringes, etc. And different health behaviors that leads to an outcome. Lastly, we talk about how this information informs what we have in terms of screening and protocols and how they interact with each other. How the segmentation of population characteristics is going to inform what we currently screen for in our established forms. Do we only screen behavior? Do we include these personal characteristics in terms of predisposition factors, enabling resources, perception of need? Do we include social support? But that's sort of like what's going to come next. But also in how this impact our protocols, the question that is being asked as civil providers, we've been asked this a couple of times in terms of then who should get tested and who shouldn't get tested. It's the ideal is to have these available for everyone, and everyone should know their status. But in terms of the scope of services that we have, in terms of what is highlighted as the population at high risk, then where should the efforts go in terms of enhanced testing? So should we test the person based on the screening that we did, and did we assess everything? Do we then, does the person then fall into the category of being at high risk and therefore gets tested? And or the person doesn't necessarily fall into that category and it gets referred to maybe a place where it gets routine testing is done. So those are different questions, or it gets referred to inside to other programs within our same organization and or other organizations such as CRCS or PCC, talk about retesting and referral services. That was what happened last week. This week we're going to talk about the environment, as we said before. We're going to actually address mostly the external environment. The healthcare system, it's changing. It's yet a new change that is impacting the field, and we're going to talk about that on our last webinar. But we're going to talk about the external environment in this case, and we're going to talk about specifically the understanding and impact of what we call the 3 A's: acceptability, availability, and accessibility when we talk about determinants of risk, when we talk about structural barriers, when we talk about how can we best implement and reach our target population when these barriers are present, how to best assess them, and how to best define a program or our implementation or our tactics to be able to reach the population we want to reach, as we have described in our segmentation. And then also we're going to talk about more hands-on concepts on or skills used in the process of mapping environmental barriers. We talk about, we have a mapping curriculum in which you can use to assess personal characteristics. You engage the population and you define who's this target population based on, as we talked just recently, based on predisposing characteristics, enabling resources, and perception of needs of the population. But then what's the macro? Then we go also the environment. And that's what we're going to, and an example we're going to use today, it's going to be stigma.
So in thinking about talking more about the environment and those environmental factors and those structural factors that we are going to sort of tease out a little more today and unpack more. It starts with the idea of the individual, right? Just think about, I'm here in the figure, I'm using the stages of change model, which we've all seen, part of motivational interviewing. Many of us use it in our counseling sessions. And so it's certainly applicable for this context. In terms of, thinking about what motivates an individual to get tested in the first place, right? Testing is not just necessarily a task. It's not just something that gets done. A person walks in, gets tested, you collect some information, and, conclusion. They have their status. If it's negative, then you ideally deliver the information that they need to stay negative, and or if it's positive, link it to care, et cetera, et cetera. But it's not just that. It's thinking about, before that person made the decision to get tested, thinking about their knowledge and information. What knowledge, information, cues from their environments are they using, did they use, to even first make that decision to get tested, right? What were those experiences? What are that person's priorities and or desire for positive health outcomes? It's all about thinking about so the factors that are supporting the decision to get tested. What makes testing a good idea for me? Is it just because I'm told to do it? Is it because I have all of these social marketing campaigns that say, because I identify as a gay man, I have all of these initiatives for, that are targeted towards MSM, and therefore, it just logically I should be getting tested because I'm a higher risk pool. Right? That doesn't really get down to the actual risk factors. That just clumps up categories. And we've talked about this, and we know this happens all the time. But it's a way of also using information that isn't stigmatizing, right? Sort of moving beyond just seeing gay men as vectors of disease. And sort of, how do we, ideally, and we'll talk more about this in the third part of the series, it's how do you use the information that we have to customize outreach testing or customize our outreach efforts, right? So that we're getting the clear information across, but we're not necessarily inadvertently alienating people. And
another thing that I wanted to add here, when we talk about, yes, this is the individual readiness, but when we talk about moving along the line of this trans-theoretical model of the stages of change model, for someone to move from pre-contemplation to contemplation, as we know there needs to be a trigger. Maybe that trigger is kind of like this combination of the environment and these influencing factors with the individual's already predisposing characteristics, right? Or the individual's beliefs on knowledge. So maybe that emphasizes and it keeps the person in a pre-contemplation stage. It can also keep the person in between the contemplation and preparation, and also the preparation to action, sort of like this belief that, maybe I did something risky, but, I'm not part of this bigger notion that, I know I'm not at risk because I don't identify as a certain population. Therefore, even though I was engaged in a risk behavior or unprotected sex, let's say, I'm not at risk, and that I know that people in this statement as an individual, I know what puts a person of risk of HIV, but because of the knowledge and belief that this is only for a specific population, and I don't adhere to that and other environmental factors, then I don't go into the action, which will be the testing part. So in other words, that leads us to, like, we know the population characteristics, we may know also the behavior that we want to change, which in this case is people not testing or unable to find individuals at high risk. And again, it's based on maybe this behavior is unprotected sex, or it's sharing needles, or how you define the behavior, the risk behavior. But what are these determinants of health? What are these structural and environmental factors that, together with the population characteristics, places the individual at risk? Is it a combination of network level risk with partners and social structure? Is it just about partners? Is it just the network level risk? Remember the questions that we asked before, MSM risk not necessarily equals individual risk, or that person who's from Latin America, recently arrived in the U.S., non-assimilated to a U.S. Culture, a gay subculture, is less at risk because of the connection is not there, and so forth. So what is this structural and environmental influencers that places our target population at risk, and thus the behavior and the outcome?
And just going along with the theme in terms of collecting all this information, right, about the individual, about their environments, we do so by indicators, right, pieces of proxy information that are suggesting something is happening, but we don't know why yet. And this is why these pieces of information are really important and integral to look at, because they're telling us parts of a story, or many parts to a story and a narrative that we're trying to capture and see, well, there's a problem here. We have epidata that tells us trends. For example, briefly looking at some epidemic from Florida, and this information we got from the Florida Department of Health. I want to point out, there's a lot of numbers up here, but the numbers that I want to point out here are specifically is the percentages addressing Black African Americans. So although in terms of total population, it's 18.8 million, roughly about 16% of the population of Florida is Black African American, yet accounts for half of the cases of HIV. Alarming stats. And we know this. I mean, these trends mirror national trends as well. And it's always, for me, while doing trainings and also as a provider, talking about these stats, talking about sort of the needs of the community, and these stark and severe social and health disparities. It's the level of sometimes how we normalize, how we don't question this even more, right? And sort of, what does that mean? Like, these numbers are significant. So how do we start collecting more information to find solutions to address these health disparities? And we're going to talk a little bit more about these health disparities, sort of how we use information, how we use data, knowledge to inform the work we do. Everything from outreach to linkage to care. Again, following the same, looking at the populations and looking at the disproportion in terms of prevalence, incidence, and what communities are being impacted. Again, certainly not an epidemiologist, but do know that data tells a story. It starts telling a story, and it's up to us to start unpacking that a little more. And that's one of the things that we want to talk about today.
And the question here is sort of like, what are these structural or environmental or socio-ecological factors that are placing this particular population? Let's talk about African American community, Latino community. In comparison to the numbers, it's high. As we see here, in comparison to the overall population, the numbers that we see here are high. One of the things that I usually hear is that information is out there, we know it. Sometimes we hear about saturation of services, yet numbers are high and have maintained, but it grows in certain populations, like in young MSM of color. We have seen more an increase among women. So what are these social determinants of health that are placing these populations at risk? And if anyone would like to share, it's sort of like, it's an open question. What do we think based on our experience, based on our work in the field, based on our expertise, based on the expertise on the location that you are or you work in and the community you work with, what do you think might be these influencing factors? And I'm going to unmute the lines, so if anyone would like to share a comment.
The conference has been unmuted.
Can everybody? Apologies, we have some technical difficulties. I think the echo is gone. Can anyone hear me now?
We can hear you.
Okay, sorry about that. So would anybody like to respond to Bolo's question? In terms of, again, just looking at the data, but more so thinking about the experiences in the field, thinking about our practices on a day-to-day basis, from just what we know, both professionally and personally, even perhaps, what is happening, or what are some of the reasons we think that these disparities exist, and even specifically more in our individual communities, right? Because this is national or state data, which doesn't capture necessarily those nuanced experiences, those individual, smaller community qualitative stories
And it might be, in general, we can talk about, it might be homophobia. In the poll that we did last week, it was stigma was rated really high, and stigma around HIV. I mean, we cannot talk about HIV without talking about stigma surrounding the field, right? And the topic, poverty. Talk about language barrier, living conditions, maybe gender norms and roles. How do they play a part when it comes to the interaction, cultural norms or values of sexual identity? We had some comments last week in terms of how, when it comes to, for example, these data, we talk about males and females, and then we talk furthermore in terms of modes of transmission, and we have MSM, but we don't have, for example, specific data when it comes to the transgender population, because they're put within this behavior, which is MSM, or they're not counted. They might be within the biological or birth gender under males, but data may be sort of like this, not specific, but it's sort of like general, and it doesn't have these particularities. It's happening, but maybe this kind of like uh, gender identity and sexual identity are part of this social determinant, how they interact with the environment, race, immigration status. So it's about thinking of all these influencing or social determinants of health and how they impact the individuals and thus these high numbers in comparison to the overall population. So I'm going to go ahead and mute the lines again, and we're going to go
The
in
conference has been muted.
health equity. So, I'm sorry, the social determinants of health and disparity. So
just getting into more about those social determinants of health that, again, we know exist, we hear in the stories, but oftentimes rarely get the opportunity to unpack these ideas a little more. Rarely do we get to sort of assess what's going on closely. And so we're going to talk a little bit more about, these ideas of social determinants and what are these specific social determinants, right? Because it's a very abstract term that means so many different things. And so we're going to address a couple of these determinants and how they inform the environments, create the environments of our target populations, and therefore also create the environments and lived experiences of our clients. Starting briefly with a quote by James Baldwin, "Not everything that is faced can be changed, but nothing can be changed until it is faced." Sort of to start that conversation, that through this webinar, we're going to be thinking about how is this information. So, for example, epidemiological information or the information that we're about to cover in terms of social determinants of health. How does this information impact my worldview, and how does this information impact my workplace? Those are two questions that we sort of want to resonate as we go through the information and through the webinar. So, real quick, some quick stats information on health disparities in the U.S. to give us sort of a general picture. Health disparities are different. Are differences in incidence and prevalence of health conditions between groups. We know that that's how it works. It's a general definition. And us as public health professionals strive to reach health equity. That is the goal. Make sure everybody can be healthy and have access to resources accordingly. Certain populations should not disproportionately suffer more than others, be unhealthier than others, right? We know this. So in terms of infant mortality, stats that say or show that infant mortality increases as the mother's level of education increases. Looking at cancer, the rates are 1.5 times higher among African Americans than whites. Conditions of diabetes, Native Hawaiians, American Indians, Hispanics, and blacks are significantly more likely to have been diagnosed with diabetes compared to whites. Again, story. Information always tells us a story. And specifically to HIV and AIDS, MSM, blacks, and Hispanics are more likely to die of AIDS compared to whites. So these are some of many of the health disparities that we as a community, as providers, address on a day-to-day basis.
And in actually reading a little bit more about this kind of data that we find, it would be, my question would be, what is impacting the mothers to, what is impacting the level of education in these mothers? I mean, is it the access to it? Is it is it sometimes transportation to it? Is it a teenage mother versus an adult one? What's happening that level of education is decreasing in mothers, and thus it's impacting, or the result may be this increase in infant mortality. And also, for example, in terms of the cancer death among African Americans, that white, are we talking about maybe less access to healthcare. Maybe we're talking late screening. Maybe we're talking about other social things, or I would talk about a specific one. We're talking about cancer. I would talk about smoking. Who's smoking more? We're talking different type of. So what is that we're seeing here, and why the impact within this specific population, and so forth and so on. So that's what we want to emphasize in terms of HIV and AIDS. We know it's around MSM, the highest amount of incidence, and that's actually highlighted within high impact prevention. But we talk about network risk, right? MSM. But why within blacks and Hispanics are more likely to die compared of AIDS compared to whites? Again, we go back to access to healthcare. Do we go back to late testing that it's actually diagnosed already with AIDS? Do we talk about not wanting to engage or have the right connection in terms of healthcare to effectively have adherence to medication? What are these different factors? So knowing this sort of like background will help us address, like the quote says, we may not change everything, but nothing can be changed until it's faced. So what are the things that we can impact, and what are the things that are a bigger thing, but we can acknowledge and be able to kind of like find ways to work with what we presented.
And sort of another way of thinking about this is, or thinking about social determinants of health. I like this image here, this circular motion, where we have certain factors, certain social determinants, socioeconomic status, race, ethnicity, sexual orientation, geographic location, right? All of these that are going to impact our health one way or another. Now, race, for example, race and sexual orientation. So, being a Latino gay man from a geographical location, that captures an experience that does not necessarily outweigh the experience as a gay man, a gay black man from a poor neighborhood. The circular motion shows that our experiences, our inequalities, are all based on personal and individual experiences and the intersections of these experiences. These inequalities are not always hierarchical. They overlap and intersect. And so we know that the social determinants are complex and integrated. So it's how do you best get more specific or figure out the details in these experiences and how these social determinants are working, how they impacting our environments or the environment of our target population or of our communities.
So and it's how it impacts us individually as well. It's what you're saying, Michael. It's the impact at an individual level is so different from how it impacts you, that impacts me, my experiences, and also imagine the population and each single. That's why the circular motion per individual. But imagine all that within the different individuals. There's an overarching theme that impacts, such as homophobia, but I may have never experienced homophobia versus someone experiencing it, and that impacting kind of like their health outcome.
Again, same theme here in terms of looking at social determinants from a societal perspective, same context or similar context: racism, homophobia, stigma, economic, socioeconomic background, job opportunities or lack thereof, food security, housing, safety, access to health care, and then how are these influencing our psychosocial context. So social networks, who's in them, community engagement, ideas of self-worth and hopefulness. Thinking about holistically the person, the community, and the health outcomes. in terms of continuing with the idea of looking at the person holistically, we try to change social norms, or we try to manipulate, ideally, environments so that we're changing social norms to improve health outcomes. Maintenance of healthy behaviors, which includes, for example, regular testing when appropriate for those high-risk negatives or unknown positives. Working with non-traditional partners to test population. For example, youth employment services. Many of us as providers either have youth employment services at our facilities, at our organization, which can draw links or referrals to HIV testing, or testing to medical services or health services. So it's finding ways and partnerships, which we will talk also more so about in part 3 of the webinar series, is these holistic approaches that can be addressed through non-traditional partnerships, and sort of addressing these factors: jobs, access to healthy food, schools, education, knowledge, access to health care, social support from a family perspective, and also from both family and friends, leadership, civic engagement. What makes me want to be part of my community? What validates me as an individual? What validates my community? All of this leads to positive health outcomes. And the trick is to find sort of the route to those conversations and solutions to these environmental barriers. Here we have in terms of finding ways or finding routes to prevention, to points of intervention where we can intervene and potentially tease out and unpack situations a little more, or find out more about the barriers that are keeping people from testing or keeping people out of healthcare. Here we have the socio-ecological model, and it's broken down into four stages. At the individual level, in terms of thinking about where we can intervene, our individual level interventions, we try to affect or influence a person's attitude, knowledge, behaviors. At the relationship level, we now get more into networks. We now try to influence or find out more about a person's peers, social networks, social interactions, whether it be with family, with friends, with coworkers. What are the social interactions, or therefore social norms of interactions or modes of interaction in particular environments, in particular neighborhoods, right? And where can we intervene as providers based on that information? In terms of the community level, how can we sort of manipulate or try to manipulate cultural norms, social norms, designed to impact the climate, processes, and policies in a given system, in a given community. And at the societal level, this deals more with policies, laws, sort of these structural tenets that influence these environments, create and inform these environments that we're in. So these are four different levels at which we can intervene for prevention and or to address health disparities, certain types of social disparities, right? And so it sort of, again, helps us to look at these finding positives, holistically, comprehensively. You know what? And we're not at all suggesting that we can intervene. It's possible to intervene and implement prevention practices at every single level to the same comprehensive degree. That is not at all the suggestion. But just to think about what are the services we provide, what are the issues we're trying to address with the client, and where can we intervene? Is it more so, does our strength, do our resources enable us to intervene more at the individual level, more so than the relationships that our clients have to the exterior community, to the exterior environments? Do we have peer educators or community health workers or any sort of community liaison that we can use to inform relationships, to reach out to those social networks and peer networks, to provide education, to provide change the social norms, assuming they're negative, right? And again, at the community level, is it more policy? Do we have social marketing campaigns? Do we use social marketing campaigns? Is that even part of our MO or our resources? Can we do that, right? It's all about using what we have to the fullest potential. And then again, those of us who potentially have an influence at the societal level, at the policies and procedural level, these are just points of where we can intervene. Again, addressing the issue of testing, finding positives, and what that means.
And this is sort of like how you can also see kind of like the combination prevention packages. When you look at the different interventions, we're talking about structural interventions, behavioral interventions, biomedical interventions, public health strategies. So they're like going at these different levels of impact in in a structural way. And we're going to talk about structural interventions. It might be society and community. On a more individual, it's the relationships and the individual. Sort of like what's the combination prevention that may work for your specific target population in achieving the goals of the programming that you have. If it's aiming at testing, but the individual, it's not like we saw in the at the beginning, the readiness to engage in testing is not there. What needs to happen before in terms? So that's when also our skills come in terms of motivational interviewing, being able to really assess what are these different, not only individual characteristics, but influencing factors to be able to kind of like reach that trigger that helps the person navigate through a process that will lead them to get tested. Maybe it's fear, maybe it's the relationship connection of what will happen if, maybe it's the community part of it with the stigma, what will happen if, and what are the societal norms, I would say. So this is also very reflective of what we have in terms of the different interventions out there. It could be homegrown interventions as well, but it's also what the combination is. And that's something that we want to explore more tomorrow. The next webinar next week, and we will use this same graphic and go into kind of like this combination prevention and how kind of like we can create a strategy around what we have. And this is where, like Michael was saying, the expertise comes in terms of, and he was saying before, testing is not just the task, it's sort of like an ongoing process that engages these different components, and being able to bring our expertise, bring the information from target population, bring the environment into it, and kind of like see what would be the best approach.
So as one of the three main goals, as we discussed last week, of high impact prevention, is to address health disparities, is to address these social determinants of health. So both the CDC and Departments of Health have made it and continue to make this factor important, and certainly are prioritizing it. Here you see an example. It's a conceptual model designed by the World Health Organization, who specifically has assigned a commission and resources to talk more about these social determinants of health and what's happening in communities, and how are these working. Again, we know social and structural determinants of health exist. Now the sort of task is to find out more specifics. How and what can we do about it? That's really the whole point of this. It's not just to talk about it happens, because we all know it happens, but what can we do about it? How can we make more sense of it? So here in this conceptual model, it's broken down into, of course, not a shocker here, socioeconomic and political contexts, right? And how those inform social position, education, occupation, income, gender, what are the gender dynamics, ethnicity, race. So at the macro level, we also have governance, the policies that influence these factors, and of course cultural and societal norms and values. We are moving from left to right. So at the macro level, these influences a social position. Specifically looking at the factors of education, occupation, etc., and knowing sort of the factors that mediate, that are relevant in this conceptual framework. So thinking about material circumstances, and again, here material circumstances refers to the enabling resources that we discussed last week and briefly discussed today as part of the Anderson model. Social cohesion. Now, this social cohesion, when I first saw the model, I did a little more research just to find out what exactly is meant by social cohesion, and it really refers to social cohesion is broken down into three factors, and that's social capital. So, in other words, sort of our power, privilege, the identities we have, positions we have, education or access to knowledge we have that allows us to have more of a advantaged position, right? And how we can use that advantaged position to, that results in positive health outcomes, meaning access to healthcare, access to work, employment, access to supporting social networks, etc. Social cohesion also has to do with social mobility and social inclusion. Again, feeling part of the community, feeling that I can move on, progress, feeling that there was opportunities for me as a person and also as a community. Then we also have psychosocial factors, which we discussed earlier, networks, social support, behaviors, healthy behaviors versus risky behaviors, and then the biological factors. Again, examples of this are certain incidences and prevalence in particular populations, in particular race groups, ethnicities, socioeconomic backgrounds.
Yeah, and sort of like what you were saying in terms of, mentioning social cohesion, and if we're talking about social inclusion, part of this, right, think about homophobia. And in sort of like when we look at the model of community and homophobia and relationships with our kind of like social, our peers or our sort of like immediate groups, which is kind of like our family, your primary groups, right? And what does that do in terms of the behavior that is here and maybe the access to healthcare system? Because I may be afraid that if I go somewhere that they're gonna find, my family's gonna find out about your sexual orientation, sort of like kind of like that felt homophobia. When we talk about biological factors, one of the things that we were mentioning last week was sort of like this versatility of MSM in terms of being the receptive partner as well, and or insertive. So it's sort of like having this versatility, and it's kind of like the reason in terms of this comparison that they're presenting as to why there's such a high incidence within this particular population, because at any given point, a man, an MSM identified man or gay man, let's put it like a gay identified man, can either be the insertive or receptive partner. So it's sort of like that enhances the risk of transmission. So it's sort of like these biological factors are also taken into consideration.
Any questions? We know we've thrown a lot of information, and so we definitely want to give you the opportunity to ask any questions or any comments that you may have.
The conference has been unmuted.
And also, Zach.
The conference has been muted.
One of the lines, there seems to be an echo from one of the lines from a participant. We're just trying to figure out, we don't know who that is yet, so we can sort of control it on our end. So we do apologize for those technical difficulties.
However, there's an option to sort of like raise your hand if you'd like to comment, and we'll unmute the line, that specific line, and or you have the option of the chat as well. But sort of like, you know, in addressing kind of like these social determinants of health, is like Michael was saying, it's sort of like this framework, and we may not necessarily be able as an individual or even as an agency to address these bigger, you know, infrastructural, societal factors. We can certainly work towards it, but it's important to acknowledge them, because this is when it comes to sort of like that interaction with our participants or clients or our community, is what we can be, we're able to kind of like affect maybe that that knowledge, and that knowledge can later transfer into that trigger that helps the person or that impacts the person in moving towards the next stage in this kind of like behavioral change for testing. So it's sort of like this, having this awareness and the circumstances, and put it as a process and not necessarily just a task, can help us navigate our population, can help us craft our intervention in terms of approach, and so forth. And we're going to talk a little bit more about the structural, the 3 A's. The 3 A's of, we're talking here of a structural barrier, sort of like, it affects the accessibility, availability, and acceptability. We have talked throughout this first hour about all the social determinants of health. And we see them as, again, at a macro level. We've just went through this. Poverty, gender inequality, migration, mobility, racism, stigma. We sort of like, kind of like repeating in a way, but it's sort of like, this is like the overarching, as we were saying, you know, there's lots to do as a society to probably affect or change, and we're working on this. But the intermediate things, we can certainly have an impact on the availability of resources. The physical environment can also have an impact. And in our conversation about this specific, we were talking about how an area may be defined as an area that is welcoming of the gay and bisexual community or LGBT community, an area in general. But however, if you go to a specific place, the environment, the norms and values inside that particular location may be totally different than what the neighborhood is reflective of. So it's sort of like, and one has to sometimes adhere to those norms and way of carrying yourself within these specific, you know, structures. Sort of like, you know, how we are to behave, or what is the way we are to be when we go, for example, into a church, or when we go to a school, or when we go to a specific bar. So it's all this physical environment may be different than where these locations are situated. Sort of like, we really need to assess kind of like these different these different influencers, I will say. The organizational structures, again, laws and policy, and all that, it's sort of like how we as individuals are susceptible to all these the structural determinants. So when talking about the 3 A's, the availability is it's simple. Does it exist? It could be the quantity respective to the population. Do I have the enough amount to be able to comply with the population? And we're going to do an example of an intervention that sort of like didn't quite adhere to these 3 A's and therefore didn't kind of succeed. The accessibility, it's not only physical, geographical, but it's also kind of like deals with non-discrimination. If discrimination or I have this felt stigma, internalized homophobia, and I'm gonna and I know that there might be some sort of discrimination. Accessibility it's not gonna happen. I'm not gonna access this services. So this is sometimes when we go again back to physical environment and organizational structures. If there's sort of like homophobia in an area, I'm not gonna go because it's gonna it's not gonna help me, and I'd rather not have things than go to a place that I know I'm gonna be discriminated against. It's about information and also economics. So these different things are part of accessibility. Transportation is another thing. The lack of transportation, the lack of enough resources that goes with availability. And accessibility, this is about social norms. This is sort of like, am I gonna be, population may a lot of times when we conduct these focus groups about condom use, and when I hear men saying, I don't want to use it because it doesn't feel the same way, and so forth and so on, that has to deal with this sort of like social and individual kind of like norms. It's like I'm not accepting the use of condom because of how I feel using them. So it's sort of like, how do you address that barrier of acceptability when your program is condom distribution? So, and sort of we need to really know what kind of like are these influencers to be able, again, to craft maybe our messaging, to craft our approach to this condom use, for example, as my intervention example, to craft my conversation and my screening with the person that I am having this individual session with, and so forth. So a way to see how this interacts with kind of like the structural environmental barriers we have, what we know as environmental barriers, social support, family support, and employment, and we saw those social determinants of risk with the accessibility and back. So we're going to show you as an example how stigma, for example, a stigma affects availability, accessibility, and acceptability. But we always have to think in terms of these structural factors that can be barriers when implementing our program. And an example is the female condom. The female condom, the question that we always present or ask in an audience, it will be, what's the availability? Does it exist in the amount proportionate to the population? What was their structural implementation? How were women going to have this access to the female condom? Is it readily available in pharmacies? Is it affordable? What will happen in terms of the non-discrimination, again, going to a pharmacy and asking for this specific condom and buying them, sort of like, if we talk about specific populations and then we have these kind of like norms and values and kind of taboos around sex, and just to go to a pharmacy and access condoms, major event, it's not going to happen. So accessibility may not happen because of different reasons. Physically, maybe it's not in every pharmacy, or was not in every pharmacy, only mostly probably community-based organizations like ours, maybe health departments, but not necessarily readily available for purchase. And the main one was accessibility. And in different focus groups, again, women were not receptive of this conduct. It's one was the use and the mechanics of it. Two, it was kind of like their relationship with their partners in terms of the use of this specific condom. So the acceptability impacted, obviously, the accessibility, and not having it available, again, it was not the right combination. So when putting together kind of like this structural intervention, we have to assess kind of like what are the norms around this specific topic? What are the norms around testing, right? What are the norms around HIV testing in the community that you're targeting? How is it perceived? Again, talking about accessibility, think about discrimination, think about the stigma around it, the information that individuals have. Does it exist, and the structured implementation of it? It does exist, but what does that mean for them in terms of that it exists? Do they have to go to your location? And if so, does that impact their accessibility in terms of transportation? Or if you bring it to their location, it is available, but how does the, for example, confirmatory thing happen, the follow-up happen? Do they have to go, again, test transportation? Or do you go back? And if you go back, how do you not, or how do you deal with the stigma of having HIV testing in a van, in a neighborhood where the acceptability is not happening, or it's not great, or the acceptability of it is only under specific circumstances that, again, are going to lead to discrimination. It's only for gay, bisexual men. So maybe women will not access your testing van, or maybe everyone will be looking around before going even there. So we have to think about how these 3 A's impact our intervention, and how do they interact with the environmental barriers.
So here with this slide, we'll go quickly through it because we've mentioned sort of a lot of these factors in terms of identifying and working with or exploring more of these social determinants of health disparities. We're going to move on to structural determinants, and these are certain topics and codes, among many, points of entry to make more sense of these structural determinants. So access to resources, income, housing, transportation. If you live in a rural area, that, again, we know this, rural residents travel greater distance to receive health care, would have to have car, transportation. That's going to affect their accessibility and availability. Just because an intervention is available doesn't necessarily mean it's accessible. And these are important factors to really think about in any implementation of any intervention. Again, with income, low socioeconomic status associated with increase of risk disease, right? This due to many reasons, education or lack thereof, lack to resources. But how do we think about these or talk about these more at a macro level, or things that we can actually start applying?
And a little bit further about again, this is accessibility, availability, and acceptability. If, for example, we're doing an intervention that is to deal with, let's say, obesity, right? And we're talking about a certain way of eating. When you don't have access to the resources that you are to use to be able to adapt your behavior and therefore have the desired outcome, it's going to have an impact on the implementation of the intervention, because the community is not going to have, for example, access to what it says here, grocery stores with a variety of fruits or vegetables that might be part of kind of like that intervention, kind of like that tool used to be able to achieve that health outcome. And we talk about the transportation and the housing in terms of it's mostly, it says, however diverse, however single men comprise 51% of homeless population. Sometimes housing plus income can lead to engage in a behavior in order to be able to increase your income, to be able to have some housing. So, or the lack of knowledge in terms of resources, where can I access them? But if you don't have transportation, how can you get to the resources that are going to provide housing, and how can that also lead you to probably change your income conditions? So we need to kind of like think of these, again, as we saw, we're thinking about combination prevention, combination of factors that influence an individual. So with this, do we have any questions?
The conference has been unmuted. The conference has been muted.
Yet again, sorry about that, those technical difficulties. We tried to work it on our end, but not having any luck. But certainly there's still the chat option, so you can raise your hand or just enter any question or comment into the chat option, and we would gladly address it.
So, and moving on, we'll talk about the different interventions that are out there, and one of these is precisely structural interventions. There are the public health that promote health by altering the structural context within which health is produced and reproduced, and these are what the structural interventions are, and they're designed to implement or change laws and policies, physical structures, social and organizational structures. I mean, these operate in sort of like the level that we were talking here, societal community. So we're talking about macro, because at all this, as you see the individual at the end, again, when I use this, this is not the cascade that we talked before, as it cascades down to the individual. Sort of like we are part of this societal structures, we're part of this community and this relationship. So by impacting this at a macro level, suggests that it's going to impact this at the individual level. So there are the individual focus approaches and the structural approach. So the individual, and again, it's the relationship between the person and society, and in which the individual have considerable autonomy. It's sort of like, this is sort of like it's my decision, versus structural approaches view individual agency as constrained or shaped by structures. And the examples here that we have is for the fluoridation.
So again, thinking about structural interventions, why are they important? Well, one of the huge reasons is because we're trying to address things we can't control. We can sort of manipulate or enhance, or we can provide all the knowledge in the world to sort of help a client or community make better decisions. But there are certain things that we have very little influence over in terms of housing, right? I mean, we can refer, but what else can we change about that environment? Socioeconomic status, living conditions. We may be able to help in our role, but there's little things we can do to, and I use the word manipulate in a very, I know, although it's a charged word, but sort of just to imply the changing of an environment, changing of factors that we have little control over or influence over. Therefore, structural interventions come in to sort of address some of these health disparities. A couple of examples here of structural interventions that have been successful. One, the fluoridation of the water, one of the 10 great public health achievements of the 20th century. Idea: put fluoride in the public water source and avoid tooth decay. This was huge, and many people, from public health backgrounds say, if only we can do with HIV what we did with fluoridation. At first you think seems simple enough, but these again are all processes. These are all again, how can we change and manipulate environments for the better to produce better health outcomes. Seatbelt laws, click it or ticket, right? There's a fine. If you're caught not wearing your seatbelt, you are fined. Again, not at all suggesting that this is the way to do it. Charge people. People have enough bills as it is, but this is a way to again manipulate and change social norms. Prioritize seatbelts because there are consequences. Bans on indoor smoking, bans of sale of alcohol to minors, and again, specifically just thinking about what are the factors that this is trying to control. So seatbelt laws, it has to do with acceptability, right? Fines, bans of alcohol, availability, trying to manipulate availability and make alcohol less available to minors, and bans on indoor smoking, again, acceptability, right? Addressing these factors and the success of any intervention is going to be contingent upon acceptability, how acceptable, accessible, and available these interventions are. And again, whether it's available or acceptable depends on the intervention itself, because it doesn't necessarily have to cover, doesn't have to be available, accessible, and acceptable in certain contexts. It all depends on the actual intervention. Testing versus seatbelt laws, which obviously very different contexts, right? So this just gives us an idea of what we're referring to, what we're talking about, in identifying structural interventions.
Another example that's sort of like recently come out in terms of, or specific to HIV, it's sort of like the HIV testing over the counter, right? Sort of like making this available to the population, and it's sort of like trying to also manipulate these norms in terms of the stigma around it. Sort of like if it's over the counter, it's supposed to like normalize, sort of like they have this equality, sort of like a pregnancy test type of thing. So it's not something so different. So it's even within these different tests in a pharmacy that you can access it, you can do it yourself. It's sort of like normalizing this routinely testing that you can do it yourself. It's available at pharmacies at a specific cost for those who can't afford it. So it's a specific kind of like structural intervention for maybe a specific population, maybe a population that not necessarily access our services as community-based organizations, but those who want to do maybe this more routinely, who just want to do this on their own, and who can afford it, and wherever it's available they can find it. So it's sort of like there's still, it's relatively kind of like new. There are advertising in television around it, sort of like manipulating kind of like these norms and addressing stigma around it. So in terms of the evaluation and outcome of it, we still, I kind of like We don't have yet any type of information. At least I don't have it, or haven't seen it yet. But it's an additional thing that it's kind of like happened just recently. However, our testing initiatives are also looking at that kind of like a model in terms of addressing the availability, accessibility, and acceptability of testing with our population in this case. Condom distribution is a structural intervention, sort of like making them available, making them accessible, and making them acceptable. And in this case, availability, one of the interesting parts about condoms, for example, to address the acceptability and availability, it's the different sizes of condoms or flavors of condom or etc. So it's sort of like the availability of different kind of like brands that might suit your specific preferences and needs to affect that accessibility. Therefore, it's available. So that's how kind of like it's working. And also with our condom distribution intervention, it's looking at where they'd be more accessible, and available. It's maybe sometimes look at just beyond one brand. It's looking at different kinds of brands, sizes, colors, flavors. And this is what sort of like routine testing increases to increase accessibility and acceptability of testing. And the New York State Condom Program, New York State Health Department has this kind of like condom distribution program that it's all around social media. It engages participants in terms of the design of the condom. It's very specific. The packaging is very specific to New York City, and it's available at most places where people can access them. So it's again, and it's not only to eligible organizations, but they also go to different kind of like bars, locations, and actually an organization that we're working really close with here in New York is putting together a structural intervention around condom distribution in a specific neighborhood by engaging non-traditional partners in this distribution effort. So it's how we kind of like craft our program and who is our target population and where we are implementing it. Any questions? We're almost there. It's going to be 12, and we have 20 more minutes.
So one of these, we've been talking a lot about structural determinants, social determinants, and how this influences acceptability, availability, and accessibility of interventions. Again, thinking of the intervention, in this case we're talking about HIV testing, for example. During part one of the webinar, there was a poll question asking about what factors, what are the barriers that keep populations or target populations or clients in general from accessing HIV testing. And many said stigma, not a shocker there. And so we're going to have a conversation, a brief conversation about how is this working, and more so not just how it works. Again, we know stigma is present. We know what stigma is. How can we address it? And that's really how can we start to sort of dismantle and sort of chip away at these attitudes and knowledge about HIV testing. So these negative contexts and conceptions and misconceptions of HIV testing and what it means. And again, it means different things to different people depending on the community that you're part of, depending on your social norms, cultural norms. So just for context, a mark stigma, right, is a mark or characteristic indicative of an abnormality. More so in terms of why it's so important, right? Why is it constantly affecting our work? Why is it provide a perpetual barrier to many people, keeping them from testing? It's dynamic, right? It's the result of perceived violations of shared attitude, beliefs, and values. As we know, it's hard to knowledge. You can transfer knowledge. Now, how that knowledge is going to be interpreted is a whole different ballgame and a whole different conversation, which is why it makes the stigma that can potentially be sort of arise from particular knowledge is going to be difficult. And so, because it has to do with the perception of needs, your health beliefs. Stigma reduces the barrier from a whole unusual person to a tainted, discounted one. Again, misconceptions, misinformation. How are people, or we know that people are coming to these conclusions and it's keeping them from testing. How do we find out more about that? And how do we sort of move away from this feeling of deviance, this feeling of a spoiled identity? It's been in the forefront as a barrier since the epidemic, and many providers and many individuals in public health, from researchers to providers to advocates, all say similar things in terms of, we know it's so pervasive and it's so prevalent, but yet it's often not prioritized in interventions, or not prioritized in how we do the work in the community. And it's difficult. I mean, that's not measuring stigma. We know there's different kinds of stigma based on, again, race, gender, sexuality. The list goes on. But in order to start addressing it, then let's be more specific about, well, what it is and what are the factors that we specifically are trying to pull out and to inform ourselves about. And in this case, it's getting people tested, and understanding the two sides of it. So there is, in terms of talking about stigma, there's two sort of components of it. There's the felt stigma, which is, again, the pervasive stigma, that fear. I don't want to get tested because of what people may say. I don't want to get tested because, only people from a certain community. Well, I'm not getting tested because I'm not gay, or I don't have sex with men, or I'm heterosexually identified, etc. And then there's the enacted stigma, which is those actual experiences of discrimination. And we know that stigma is dynamic and works and under these two components, and is constantly influenced by our social interactions, by our environments. So how do we, get past that, so to speak? And meaning not to be all idealistic and optimistic, although I certainly am a glass half full kind of guy, but it's really about how can we be practical. We know this happens, let's be practical about it. How can we include that in our assessments and the information we have about the community? And this is, again, why? Well, why? Why should it be addressed? Well, because of this, which is what we know. Low uptake of prevention treatment because of stigma. Poor adherence to prevention treatment because of stigma. And again, as I mentioned, one of the problems or issues in terms of allowing us to learn more about it or see its effects in the community is there are relatively few studies. In terms of again, going back to those 3 A's, how acceptability, accessibility, and availability can be impacted by stigma, right? Individuals who believe they're HIV negative often perpetuate stigmatizing attitudes while still engaging in unprotected sex. In terms of accessibility, lack of knowledge and safe space for disclosure leads to less HIV-positive people disclosing status. Availability, lack of programs for HIV-positive people leads to increased discrimination and unprotected sex. Studies, research, all tells us this. We know this also from our personal experiences and professional experiences, doing the work, being experts in the field. So, how do we use what we know to inform the work?
But one of the things that I wanted to add on this in terms of the 3 A's and sort of like examples are things that we sometimes, again, in our experience with her, of, for example, the other end, those who are HIV positive, right, and they have these rejection experiences all the time because because the acceptability or the perpetuation of stigmatizing attitudes, even though the individual might be only under the perception that they are HIV negative because maybe the last test was a year ago or a year and a half ago, or a certain period, or just because the person does not fully puts himself as someone that is at high risk. Again, with the safe spaces, and it also goes with the implementation of our kind of interventions. If we have mobile vans, if we go to a neighborhood just without a ban, but talking about HIV and AIDS, we have to kind of like, sort of like what we do with our Latino Religious Leadership Program, kind of like probe and talk about maybe health disparities in general, the perception of health, what are the different things, what do they, and then include maybe HIV and AIDS in terms of this conversation, and then through that motivational interviewing with, you know, the interaction of the community, you'll be able to assess whether the space, the knowledge, and if it's safe space to kind of like bring that, bring the topic of HIV specific, or more so testing or condom use. So those are kind of like the ways in which we can see how these interact, and also we can here put additional one, transportation, we can put race, we can put immigration status, access to healthcare, and so forth.
So we started part one also of the webinar just talking about formative assessments, and just, you know, again, formative assessments or assessing the work we do, learning about the community, and the importance of an assessment that's continuous, so should be continuous, right? We should ideally always be checking our work just to make sure that what we're doing is working and it's effective, successful. And so we started the conversation with the first couple of steps, which referred to investigating data. So looking at some epi, looking at some statistics, and making sense of it. What is this telling us, right? And we sort of covered and identified some of the meaning and explored what this information means in the context of the work that we do. And so now we move on sort of to the second piece, and it's really second but ultimate and finalizing piece is identifying and addressing these factors. So finding out more information which will influence the interventions that we conduct in the community. Finding out who are those gatekeepers. Community observations is, again, also a very key part, and we're going to talk about, we're actually going to soon move on to a tool that we can use in our community mapping with an exercise we like to call mapping stigma, and we'll talk more about that in a bit. Conducting spot interviews, finding people, the clients that we serve, getting information about the resources in a neighborhood, getting information about what do they think about the resources that we as providers are providing. Interviewing key informants. Again, these could be peer educators. These could be people who tie you back to the network, especially more particularly emphasizing the networks of our target populations. And as an option, of course, is also focus groups. Again, we know that this is time-consuming. We certainly encourage you to think about these steps and think about what it means to have a continuous assessment. And we know that there's just not the time or the resources sometimes to do every single step of these assessment. But at a minimum, try to do 2 or 3 of these components. So community mapping, that's walking through your neighborhood or selected neighborhoods or selected communities, to try to inform yourself of more about the resources, what's there, what's not, who are the people, and what are some of the barriers and social determinants that we can observe here, and then interviewing people from those communities or having a conversation. Really, it's about having these conversations with people from the community who can give you more of an insight and tell you more about those indicators. That's going to paint the picture of, well, what are the barriers, what are these environments that we are dealing with that are creating these experiences for these clients that are not keeping them from getting tested? Is it what we think, or are there other factors that we haven't been able to explore deeper? The only way to do this, or one of the ways to do this, is again, indicators, data indicators, we talked about that, and now physical indicators. So physical indicators, what are things I can see, things that we can see as providers that is going to inform us about the environment and what is happening in environments. And these are just a couple of examples, certainly not an exhaustive list again, the existence of bars, existence or high concentration of cigarette butts, used condoms on the floor, syringes, signs announcing sale of alcohol beverages in an area. And we can go on and on and on about physical and tangible components of an environment, of an area that's going to tell us more about that area and to potentially lead to the people in that area.
And one of the things that I wanted to sort of like just quickly add around the steps and the physical and data indicators is that, as you are implementing the intervention, we recommend to be aware of kind of like this process of identifying indicators, of engaging the community in asking or probing questions in terms of the navigation of services. It's something that and that's what we refer in terms of constant. It's not an isolated task, and again goes back to this phrase that we've mentioned throughout the day of HIV testing not just being a task of the actual testing, but actually a process to reach to that ultimate goal, which is providing the test to an individual who we have identified as being at potential high risk. And at that point, one of the, and we will talk this more about during the next webinar and last webinar, it's about how that individual identified as potentially high risk can be kind of like your link towards help you navigate certain networks, and kind of like, again, the combination prevention do kind of like this social networking, not talking about the PHS, but in terms of navigating and links, and kind of like walk you through, be someone who can be a partner and collaborator in accessing these networks. We talk about here gatekeepers. Gatekeepers might be in a community, but this particular person that you tested and identified, or individuals, maybe one, maybe five, can be your gatekeepers toward these specific networks. They can sort of like provide you the information, give you the access, and be the link between these networks.
And in terms of just having indicators or being more specific about the certain physical indicators that we can use in a data collection process, we have the following. So, and I posed it, if stigma, and I'm operationalizing stigma to address a couple of things, right? Because sometimes when people talk about stigma, they're referring to fear. Other times it's shame, right, which connects with embarrassment, or the misinformation. So depending on those specifics, if stigma is keeping people from testing, how can we understand this a little more? Meaning, how can we start getting to some potential solutions? And not solutions in terms of let's get rid of stigma. We would love that. But how do we, in the presence of stigma, how do we still get people to get tested? And that's really what we're talking about here. well, I'm going to show you a community mapping tool, but before I get to that tool, these are certain questions and things to think about prior to doing any community mapping intervention, any community mapping exercise. Some physical indicators, these are things I can see that is reinforcing and or addressing stigma. So what are the types of buildings? Is there a concentration of churches, schools? Are these schools affiliated to any types of religious backgrounds? What is the concentration of hospitals? Again, what is the affiliation of the hospital in the community? What reputation does the hospital have in the community? What are the community centers, if any, available in particular neighborhoods, areas, communities? What are the services? Resource centers. Are there resource centers? What other health services do they provide? Are there CBOs, right, in the area? And what services are present in those CBOs? And what are the target populations of those CBOs? Is there a service center or any sort of community center to address the needs of LGBT people? Again, that it's going to tell you, it's going to inform you about accessibility and acceptability and availability. All of these address different factors, those separate 3 A's, to get you thinking about what can be potential interventions and what will be the impact of those interventions in these communities. People, who are the people in these areas when you're doing your community mapping, and you're walking around and you're conducting observations? Can you make any links to any particular networks? Again, networks also, it's not just about observing the people, but talking to the people. And what are the people telling you about the social networks in those areas or the social networks that they are a part of? Neighborhoods, what do the neighborhoods look like? Who are the people in those neighborhoods? What are the resources in those neighborhoods? Certain demographics about neighborhoods, race, ethnicity, class, gender, gender expression, sexuality, right? What these other pieces of information, these other demographics that are going to inform me about the people in an area. I mean, how can we use this information to potentially manipulate our environments to address these fears, to address these different types of stigmas? Are we finding out more information about particular areas and neighborhoods where we can, assuming we have that resource, sending out a mobile unit or conducting outreach in these specific areas? Based on the information that we learn about redefining our population, and based on the information that we gained more about certain social determinants, or being more specific about what are the social determinants that are impacting our community, can we customize outreach efforts? Can we change sort of the messages, the information? Should we? Again, assuming that it's even necessary. But it's just something to think about. What does our messaging look like now? Who are we targeting? How are we targeting them? What is the information we're providing to these communities? And can that be customized based on the new information that we are getting from redefining our population, from conducting these community observations, right? Again, thinking about the messaging, thinking about the population, thinking about the communities. Based on what I learned, or what we learned, from talking and interviewing to select members of the community, to those gatekeepers, where can I potentially influence social norms? These gatekeepers have an implied sense of respect in the community, right? Certain gatekeepers. So how can we use that to our advantage to manipulate certain social norms or cultural norms? In a different way than perhaps we haven't before, right? I mean, we recognize, many of us, we know about gatekeepers, we know about the usage of peer educators and community health workers. We know that this is not new information, but the task here then becomes, well, how we have these resources and these access to these communities, how can we look at it different? How can we use it differently? Or what new information, potentially, can we extract that we can use to our advantage? Over the course of 30 years, the epidemic has changed in terms of population, in terms of who historically is being impacted. So then the challenge then becomes, well, what's happening? I mean, or at a minimum, how can we really start constructing and being more strategic about, addressing these needs in these communities and to these target populations. And what other needs can we address? Sometimes, and we know this, in terms of priorities, getting an HIV test may not be a priority of specific people, despite how much risk, despite their level of risk. It could be getting food, working, finding employment to take care of themselves or take care of their families. That's a priority. So then, in addressing potential employment needs and addressing potential needs to provide more income, then if the second priority then becomes we can sort of pull those people in, address the need of employment, of income, and then have the conversation about HIV or health, embedding the conversation of HIV in terms of holistic health. This is what it means to keep working. This is what it means to be healthy. This is what it means to have positive health outcomes. Holistic, comprehensive. And all of this this information we can get more so from that continuous process of assessments.
And one of the things that I wanted to add when we talk about, or when we process the question of, what other needs I can address, sometimes we feel about a specific group of people, a handful of people, or specific individuals that I interact one-on-one. But if we're assessing the community and we're seeing that there's a need in the community, what can I do in terms of providing this macro kind of referral? And that could be through our messaging. That, there's this type of organizations or partnering. That's when partnering comes in. It's sort of like creating this messaging around addressing that particular need in terms of food is a priority rather than a test right now. So what are the services available for the community? Because it might not just be that individual, but many individuals within that community that are experiencing the same, or whose priority is the same. So by doing it this kind of like community-wide in a message framing kind of way, you will sort of like address a need and then sort of like move maybe the individuals or that particular community towards kind of like the desired output that you want. Again, the process of testing. So that's what sort of like addressing this potential needs at a semi-macro level work together with these partnerships that we're going to talk about. So it's it's seeing how this like Michael was saying, what does having a lot of churches mean in terms of social norms, for example, and how can my messaging manipulate those established social norms within that community because of how the surrounding is constructed to be able to bring the message of testing into it. So it's sort of like seeing how these interact, what's the need, and how can I address it in a partnership macro kind of level to be able to access my potential population.
This is just a tool that we've used here, we've used with other providers. That's useful in terms of conducting community mapping. We call it, you can do community mapping, and depending on what you do with the information, it could also sort of serve as a stigma mapping. We're essentially looking at the indicators that I mentioned prior in terms of buildings and people, etc. What are you learning? What information are you gaining about those people, about those communities? That leads you to believe, well, not to believe, but that leads you, that reinforce that there is a stigma here, or what are ways to address or go around the stigma to get people to get tested. So like area, streets, you can put streets here, what I saw, experienced, who was there, what did I see, where was it in terms of maybe specific cross streets or specific neighborhoods, what time of day, and the why. So I saw this, but why was this happening? If I saw a specific group of people congregated in an area at a certain time of day, why was this happening? What other pieces of information can I get to sort of see why things are occurring in a specific area? Signage in a field, so any sign. This could be liquor signs. This could be anything from a no trespassing sign to a signs about traffic, parking, signs that control human traffic, so to speak, or people walking on certain sides of the street, or people walking in certain parks, certain areas, certain times of the day. And what are those signs trying to control, or what are those signs how are those signs informing you? Of course I mean literal signage, like stop signs, and annotation. So this is where you write down sort of your interpretation. So wants, needs, likes, dislikes about what you saw. What sort of values did you see in a particular area, or people grouped together? Did you see a lot of families together, friends? Is it family setting? Is it a social setting? Was it more for a group of constituted bars in the area? So this is where people come and congregate and socialize, versus other areas that are more oriented towards family and children. So this all informs you about neighborhoods and your communities in conducting any community mapping exercise. And then this is just an option, highlights of photos. So any pictures that you take, we conduct a lot of community mapping here at the Commission to inform trainings, presentations that we do in the community or for our providers. And so we're big fans of taking a lot of pictures and then sitting down and doing a content analysis of, so what are we learning? What are these pictures showing us? And what are potential meanings behind these pictures? And it really does constantly inform the work that we do in assessing practices, assessing what's happening in a community. And in order to find ways of addressing the needs of the community through testing, through linkages care, retaining care, and really getting to having all this result in positive health outcomes. Again, this is just a tool, something else that you can use and sort of change, manipulate to your advantage to collect information that is going to be relevant to you to do the work.
And what you do with this is sort of like after the mapping, you reflect and discuss on the different findings. It's usually good to do it at different times. In particular emphasis, yes, everything is important. Particular emphasis on the signings. Signing can tell you a lot about how community gets informed and how also sort of like messages can tell you a lot about messages can be stigmatizing, messages can be racist, messages can be about different non-healthy behaviors and so forth. So messaging can tell you a lot about what the community consumes or what the community, how the community interacts, or how the community keep that community in place or not. So messages, whether it's a stop sign or a cameras around or protected by the police type of thing, and commercial messaging helps you a lot when it comes to what's happening in the neighborhood. And then what you do after that, remember we have our initial personal characteristics or population characteristics, you add to that. So from a single individual, we went to kind of like a target audience. And as you see here, we included more sort of like certain values, like what does a conservative upbringing mean for that particular population that is between 25 to 35. We keep the self-identified gay that do not know their HIV status, that engage in protected sex with multiple male partners from a specific county with no stable housing, yet another, structural determinant of health or influencing factor. Unemployed is another one in terms of accessibility, limited access to transportation, again, access, no health insurance, access. So how does information translate into your initiative. So if it's about access and there's a need of a stable housing and incomes, then what would be my messaging and who should I partner with to be able to facilitate these resources to this particular community. So, and moving on, last but not least, we kept saying HIV testing is not a task but a process, and everything comes into place to be able to reach this ultimate goal. And at the end, what we need to do once we have established this kind of like target audience is go back to our screening and protocols. And as we reviewed before, how does that screening captures what we have here in terms of the structural barriers, and how does that affect my protocol and vice versa. So that's what kind of like helps us narrow down this proposes the problem, that kind of like this is what we need to assess, and then next week we will look at the different combination of approaches that we may be able to use to, for example, provide HIV testing to this particular population of a specific country in terms of lessons learned, best practices, and tools. Any questions?
The conference has been unmuted. The conference has been muted.
So every time I unmute the phones, it feels like we're in this scary movie
In the
with
cave.
the echo. But feel free to send us any questions. You have our emails. Don't forget to complete and send us your homework. We are extending the previous one. It might help to maybe do complete the first one with the second one that we're going to send in terms of this stigma mapping, and we'll send you some additional tools. Feel free to email us with comments, questions. Michael and I are here to respond to any inquiries, any comments or questions. Remember, we have our final webinar next week, same day, in terms of day of the week, Wednesday, September 18th from 10:30 to 12:30. And you'll be receiving this information, what we presented today, plus additional articles as we sent last time for your review.
Thank you again for joining us today for part 2 of Finding Positives. And we definitely look forward to next week and sort of closing up the series and addressing more so how we can put everything we've been talking about into practice, and how we can include it in policy and protocols that we can develop at our respective agencies to address this finding positives and what that means for us and what that means in the community, and how we can be more effective in providing those interventions.
Thank you, and have a great week. And we'll talk to all of you next week. Thank you. Bye.
Thank you. Take care.
Thank you. Please stand by.